Hello, my name is Lucas Pooh, and I am a junior at North Allegheny Senior High School in Pittsburgh, Pennsylvania. So, we probably all have heard of lung transplantation, the established treatment for end-stage lung diseases, where the recipient's lungs are taken out of the cavity and switched with a pair of donor's lungs. However, for this process to be successful, a crucial consideration is to ensure that there is a precise match of lung sizes between the donor and recipient. The reason is because lung size mismatches contribute significantly to increased post-operative complications and decreased survival rates. Due to the importance of size matching, here comes the question: how do we measure lung size objectively? In normal individuals without any obstructive or constrictive lung disease, ideally, their total lung capacity should be equal to their lung volume and could be measured by a pulmonary function test. However, since there is no way for a donor to perform the test, in practice, physicians use the predicted total lung capacity, or PTLC formula, to estimate their lung volume for size matching. PTLC predicts the total lung capacity based on a person's gender and height, currently acting as the gold standard in clinical practice. In PTLC's practical application, the PTLC ratio of both the recipient and donor is compared to determine size matching. If this ratio between the donor and recipient is greater than 1, then the donor is considered oversized. In this scenario, where large lungs are transplanted into a small thoracic cavity, the risk of delayed chest closure, atelectasis, and surgical wound complications is significantly increased. On the other hand, when small lungs are transplanted into a large thoracic cavity, the risk of post-transplant pneumothorax, hemothorax, and bleeding greatly increases. However, one huge problem with PTLC is that it was created using the healthy population, but the lung sizes of transplant recipients are very different from healthy lungs due to lung diseases. For example, the three people in these images have the same gender and a similar age, height, and weight. From Figure B, we can see that in severe chronic obstructive pulmonary disease, or COPD patients, the lung size are much larger than that of healthy patients shown in Figure A. In fact, the actual TLC could be as high as 150 to 175% of predicted. On the other hand, in idiopathic pulmonary fibrosis patients shown in Figure C, the lung size is much smaller and the actual TLC could be as low as 50% of predicted. In contrast to PTLC, chest CT scans can offer a three-dimensional view of lung volumes in real space and is considered the most accurate for lung volume measurement. However, unlike PTLC, which is accessible from donor and is easy to calculate, CT volumetric assessment is rarely available for donors and is more time-consuming to measure the lung volume. So, I was really curious about whether it is possible to use machine learning to develop prediction models to facilitate this procedure, which can eliminate CT scans' limitation of inaccessibility while keeping PTLC simplicity aspect, and I believe that this was a very interesting and important research problem that I could tackle. Initially, my goal was to develop models to predict the lung volumes, since as its name implies, it is a lung transplantation procedure. However, as I analyzed CT scans, I realized that lung transplants should not only consider the lungs, but also the thoracic cavity and heart. My reasoning was that lung diseases actually might change the cavity size that might make a pair of lungs not match. For example, in recipients with idiopathic pulmonary fibrosis, the thoracic cavity after explant might be smaller than predicted, leading to complications associated with oversizing. Through extensive literature review, I found that previous studies all ignored the potential effects of surrounding structures like the cavity and heart, which motivated me to be the first one to consider them and reveal this oversight. As I conducted experiments with the help of my mentor, Dr. David Wilson, who provided me with a dataset of over 4,600 chest CT scans, I developed prediction models that demonstrated very promising results. As a result, I was able to give a 20-minute oral presentation at the SPIE Medical Imaging 2023 International Conference and publish a first author paper in the Journal of Medical Imaging. At SPIE, I received feedback from world-renowned experts on how this is impactful work, but a potential limitation is that the dataset I utilized was from a single institute and that predicting even more geometric measures could yield more benefits. This is precisely why I continue to work on this project, which is my current submission to the Davidson Scholarship. Essentially, I extended my previous work to improve it in all aspects, utilizing more than 1,600 chest CT scans from the National Lung Screening Trial public dataset. I also computed the width, height, and length of these major chest anatomical structures and developed prediction models to predict these measures from only subject demographics. Again, as demonstrated by my experiments, the results are very exciting. To further confirm the usefulness of the developed models, my next step involves clinically validating the tool in facilitating lung transplantation. I am excited to share that I will be collaborating with Dr. Sanchez, a lung transplant specialist at UPMC, to compare the impact of lung size predictions generated by my models with those derived from the PTLC formula. Currently, Dr. Sanchez is actively collecting the necessary data for this comprehensive study. Thank you.